And we continue. Next speaker is from Japan, Eiichi Ishii, lymphoma in children. It's excellent report. And I think it will be because you know the results of some cases. We have refractory and this is explanation.
Thank you very much, Chairperson. And ladies and gentlemen, today's my talk is lymphoma in children, modern approaches on treatment. The first slide shows the annual number of childhood leukemia and lymphoma in Japan, which was registered between 2008 and 2010. Among them, non-Hodgkin lymphoma, the number of the non-Hodgkin lymphoma is about 100 to 140 per year in Japan. Next slide shows the frequency of pathological subtypes in childhood non-Hodgkin lymphoma in Japan. B, non-Hodgkin lymphoma including bucket and diffuse large B-cell lymphoma as about 49%, followed by the T and B lymphoblastic lymphoma of 31%, and ALCL in 13%. In Japan, we have tried several clinical trials for non-Hodgkin lymphoma, which was organized by JPLC study. Among them, BNHL03 and ALB NHL03 studies has been applied for mature B-cell non-Hodgkin lymphoma and advanced lymphoblastic lymphoma until 2010. So I'll show these main two studies in this slide. First slide, I'll show the ALB NHL03 protocol for advanced lymphoblastic lymphoma, which consists of vincristine, prednisolone, cyclophosphamide, Ara-C, ranolibicin, and high-dose methotrexate, which is almost identical to the protocol for ALL. This slide shows the outcome of the patient with ALB NHL03. 5 years overall survival and event-free survival was 82.9% and 77.9% respectively. There was no difference in the outcome between the T and B cells. However, the outcome of the patient with stage 4 was better than those with stage 3. Also, those who attained to the complete remission showed also the better outcome than those without remission. This slide shows a comparison of outcome of lymphoblastic lymphoma in different protocols. As you can see, the better outcome was observed in BFM90 protocol. 5 years event-free survival was 90% for stage 3 and 95% for stage 4 compared with our protocol. So I'll show the schema of BFM90 protocol for LBL in children. As compared with our protocol, same drugs are used in this protocol. So I compare the drug dose at the induction phase in different clinical trials. In first 3 trials, BFM90, BFM95, and ALB-NH03, clear association between high-dose L-asparaginase and better outcome was apparent. However, in other 2 protocols, 2 protocols used the high-dose L-asparaginase. However, the prognosis was not improved. In the next slide, I'll show the treatment for BNHL. We use the BNHL03 protocol for BNHL. Each patient was classified in one of the 4 groups. Group 1 included the stage 1 or 2 resected tumors. Group 2 included the stage 1 or 2 not resected tumors. And group 3 included the stage 3 and CNS negative stage 4. Group 4 also included the CNS positive stage 4 and BNALL. We use the different protocols according to the stage. I'll show the outcome of the patient who are treated with BNHA03 protocol. 4 years event-free survival was 94.4%. The difference was observed. The difference of the outcome was observed between the different groups. However, there was no difference in the outcome between the different histologies. Burkitt lymphoma and diffuse large cell lymphoma was not different in the outcome. This slide shows a comparison of the outcome of stage 1 or 2 BNHL in different protocols. As you can see, the best result was observed in BFM90 and LMB89 European protocols compared with ours. However, in those with stage 1-2 non-directed tumors, the better outcome was observed in our protocol compared with others. This slide shows the result of the patient with stage 3 and stage 4 and BALL disease, and almost the outcome was almost comparable among the different protocols. So in my third talk, I'll talk about the treatment for ALCL. This is the first international ALCL99 protocol. The aim of this protocol is to confirm the appropriate usage of methotrexate. In one arm, methotrexate dose was 1 gram per square meter for 24 hours. In another arm, methotrexate dose was 3 grams per square meter for 3 hours. However, this slide, as shown in this slide, treatment result in 2 arms was almost the same. So, we can conclude that usage of methotrexate will not influence on the treatment result for ALCL. So this slide shows the targeted agent for NHL in children. Several agents have been used under investigation, like that. Among them, rituximab and crizotinib has been applied in Japan for the next trials. Maybe some effect with using this kind of drugs can be expected. So I'll summarize the current approach for NHL in children. For LBL, chemotherapy with AL type with using high-dose asparaginase is appropriate. Targeted therapy is under investigation. For BNHL, chemotherapy according to different stages can be used. Rituximab is available for refractory disease and also freshly diagnosed disease. For ALCL, ALCL99-based chemotherapy is acceptable, and targeted therapy for CD30 or IALK will be useful in the future. This shows all of the members of the JPLC Lymphoma Committee. Thank you very much for your attention.
Thank you so much. Questions? I have a question. You mentioned that rituximab, your new approach, your proposal to use rituximab only in resistant cases.
Yes, in this case, I mentioned that rituximab can be used for refractory disease. However, in our next study, rituximab will be used for the patient, all of the patients with newly diagnosed.
From the beginning.
But
But my question just, if you used rituximab in resistant cases, how was the response?
Partially responded, I can observe, for only a small number of the patient, but not complete.
Thank you.
May I add one question from the pathologist point of view? I just saw that you have quite many cases of pediatric diffuse large B-cell lymphomas in comparison to example given the German cohorts. And can you maybe describe the clinical features of these lymphomas? Do they kind of seem different from the Burkitt lymphoma population? And that is the first question. And my second question would be, do you know how many EBV-associated cases you have got in the B-cell lymphomas in Japan?
Yes, for the second question, it's very difficult to, for example, EBV-associated non-Hodgkin lymphoma, the incidence is very high in Asian countries. However, we are using different protocols for those with EBV-associated non-Hodgkin lymphoma. Okay?
So you check every lymphoma for presence
and
of
for the
EBV?
first question, you mentioned about the histological difference. Would it be influence on the prognosis of the patient?
Sorry, I couldn't understand that. From the
In Japan, all of the patients, B-cell, mature B-cell disease, would be treated with the same protocol, regardless of the histological subtypes.
Yeah, that's the same, but it doesn't. Nevertheless, there could be differences. I mean, in the clinical first-line presentation of the lymphomas.
At least the prognosis is almost same.
And also the initial clinical presentation. I mean, they also have ileocecal tumors or Waldeyer ring presentation. Okay, thank you.